Hello guys, this is me Dr. JK, and today we will discuss about juvenile ossifying fibroma. In our previous lecture we have studied about ossifying fibroma, but today we will discuss about juvenile ossifying fibroma, that is also known as juvenile active ossifying fibroma and juvenile aggressive ossifying fibroma. Juvenile ossifying fibroma are distinguished from the larger group of ossifying fibromas on the basis of the age of the patients, most common site of involvement, and clinical behavior. There are two patterns of juvenile ossifying fibroma. Although they are different histopathologically and having different clinical features, they are trabecular form and the semomatide pattern. Okay, the semomatide is more common than trabecular by a ratio of approximately 4:1. So it means that semomatide is more common. Okay. Clinical and radiographic features: they grow rapidly, they are well circumscribed, they lack continuity with the adjacent normal bone. Circumscribed radiolucencies that in some cases contain central radio-opacities. So on a radiographic examination, you will see circumscribed radiolucencies, and in some cases they contain central radio-opacities. Okay, in some cases they may show ground glass appearance on radiograph. This ground glass appearance is characteristic of fibrous dysplasia, but remember, we can find this ground glass appearance in some cases of juvenile ossifying fibromas as well. Okay, if they are present within the sinus, they will cause radiodensity and often create a clouding effect that may be confused with sinusitis. Here is the CT scan of a patient given with coronal section, which shows the lesion over here, right maxillary sinus, of a 12-year-old girl. Clinically, the tumor was growing rapidly. Here you can see it is penetrated into the lateral nasal wall, and it involves the inferior orbital rim area and also the anterior and lateral maxillary sinus area. In next image here we can see the radiolucent and radioopaque lesion. The radiolucent area lesion is present with radio-opacities present between these radiolucency. Okay, so we will continue our clinical and radiographic features. These ossifying fibroma, they have wide age range. It varies from 6 months to older than 70 years of age. Okay, both forms they are similar radiographically, and growth patterns are similar, but the trabecular form is diagnosed initially in younger patients. The mean age of trabecular juvenile ossifying fibroma is approximately 11 years, and that of semomatide is 22 years. Okay, there is male predilection in the ossifying fibromas, and it is more commonly they are found in the maxillary maxilla. Okay, in the maxillary jaw. So cortical expansion may result in clinically detectable facial enlargement. They are the juvenile ossifying fibroma, they are diagnosed on the routine radiographic examination if they are small, but if they are large, they will of course they will cause swelling, and they may be detectable facial enlargement will be there, and then we can go for the radiographic examination. Okay, the semomatide variant that's most commonly found outside the jaws, with 70% arising in the orbital and frontal bones and paranasal sinuses. Okay, one characteristic of the juvenile ossifying fibroma is that it causes impingement on the neighboring structure, due to which there can be complications. Lesion arising in the paranasal sinuses penetrate the orbital, nasal, and cranial cavities, which we have shown in our previous figure, that the lesion was in the maxillary sinus, and it was penetrating the lateral nasal wall, and it was penetrating the orbital wall as well as the involvement of the anterior and lateral maxillary sinus. Nasal obstruction, exophthalmos, and proptosis may be seen in such cases. Rarely temporary or permanent blindness can occur. Okay, if it is present alongside the cribriform plate or near the cribriform plates, it may cause intracranial extension. Okay, the juvenile ossifying fibroma, they are well circumscribed. Okay, and they cause just the impingement of the neighboring structure. So the frontal lobe is typically elevated without any associated neurological signs. They rarely causes meningitis, and in some cases semomatide variant, they are maybe you may find alongside the aneurysmal bone cyst. Okay, such cystic changes tend to occur in younger patients in the first and second decades of life. What are the histopathological features? These features are very important. They may come in exam and they can ask you about the histopathological features, and these histopathological features, they resemble with different other lesions, so you should keep in your mind that on the basis of histopathological features you can distinguish this is the juvenile ossifying fibroma. They are non-encapsulated but well demarcated. The tumor consists of cellular fibrous connective tissue, some areas that are loose and other zones that are so cellular. Okay, the myxomatous foci are present and associated with the pseudocystic degeneration. There are few mitotic figures present, okay, and small cluster of multinucleated giant cell are also present. The trabecular variant shows irregular strands of highly cellular osteoid. The semomatide pattern forms concentric lamellated and spherical ossicle. Okay, so we can differentiate between trabecular and the semomatide pattern on the basis of histopathological feature as well. In the trabecular pattern, it shows irregular strands of highly cellular osteoid, whereas semomatide pattern shows concentric lamellated and spherical ossicles. Now we'll discuss about the treatment and prognosis. Well, there is uncertainty about its treatment and prognosis. Many of the juvenile ossifying fibroma, they will grow slowly and progressively. Okay, some juvenile fibroma will show rapid enlargement, and it is usually it is present in infants and young children. Okay, smaller lesions will need complete local excision or thoracocurettage, but the rapid growing lesions will need wider resection. In the the other ossifying fibroma, the recurrence rate was very less than this. Here the recurrence rate is very larger than that of the ossifying fibromas. Here we have the 30% to 58% of recurrence chances. Okay, the malignant transformation has not been documented. So the ossifying fibroma, in the ossifying fibroma we have very very less chances of recurrence, but here we have very more chances of the recurrences, plus the malignant transformation has not been documented similar like the ossifying fibroma. These are the references. I am hopeful that this lecture was fruitful for you, and you will learn something about juvenile ossifying fibroma from this lecture.